they're going to shorten that window there, and there will be a request to state that CCGs need to be present and participating in those post-admission or pre-admission CETRs and CTRs going forward. So there's going to be an increased sort of onus on yourselves to make sure that you're contributing to and supporting that process with your colleagues around the system. There's going to be a letter that we're waiting from the national team coming forward to support this and provide a little bit more detail. So as soon as that comes out, I'll make sure that's shared with the SROs for the Learning Disability and Autism Agenda, and it will come down to yourselves. Ongoing scrutiny, and obviously I'm sure you've felt it across the South East around learning disabilities and mortality reviews. So there's an expectation that all outstanding reviews are completed by December 2020. There's some more detailed information again coming out about this. We're working really closely with North East CSU to understand what their trajectories look like and what their backlog is. Ray James has assured us from the national team that Next will deliver at the end of December and complete all of their backlog of reviews, so we're hoping that the impact on CCGs is minimal. There potentially will be some reviews that do come back down to the system from Next, but we're working really hard with them to make sure that it is just those reviews that can't be completed because of other legal statutory processes that may be related to SJRs, ongoing safeguarding issues, coroner's reports, etc. So we're working hard to do that. We have asked all of the SROs for the Learning Disability and Autism programme to now submit data via the care room on a fortnightly basis, and we're just putting in place a new governance and assurance process, for want of a better word, I don't like using that word, and support mechanism, so we can get some regular meetings in the diaries with your local area coordinators and your PMOs, and if necessary the SROs for transforming what was Transforming Care's now Learning Disability and Autism Commissioning Agenda, to see what we can do to support you with that. It will feel like that there's an increased amount of scrutiny on this piece of the programme, but there's a really clear expectation that those reviews are completed by the end of December from the national team, because we're having to put in the assurance around that. We've got individual trajectories, and we have requested information from yourselves to detail how many reviewers you have in the system, so we kind of have an indication of what that run rate would look like for each of the CCGs across the South East, and we'll be picking up those conversations in a bit more detail with yourselves going forward. There's additional funding to support this, and we've identified that with you in terms of the long-term plan funding, but I'm also aware that there's still an ongoing conversation and a very slight possibility that there could be some more funding to help this, but we're just clarifying that with the national team at the moment. The next piece, whereby there is going to be an increased amount of scrutiny and attention, is around that reducing that inequalities piece by focusing on our annual health checks, and making sure, so if you could just go back, could you go back, Jan? Thank you. Making sure that people with learning disability have got access to screening, and specifically their flu vaccinations. So working hard, as I've said before, to bring forward those risk-assessed annual health checks. So bringing those those patients who are more vulnerable than others in this cohort, bringing their annual health check forward and making sure that that's being aligned with the delivery of the flu vaccination. There has been some additional funding announced for this as well. So on top of the DES, the Innovation and Impact Fund, I think it's called, certainly got impact in there somewhere. They've identified that there is going to be some additional funding for GPs to help them to do this. We're setting up a task and finish group. Alison Macmillan's leading on this work for learning disabilities and autism, and we're hoping that colleagues from mental health will be joining us, and we can do a joined up discussion around annual health checks. So that task and finish group will be set up, and we're going to the Primary Care Restoration and Recovery Board on the 22nd of September to talk to some of the PCN leads and the GPs across the South East to see how we can support them and what needs to be done to increase the uptake of annual health checks for people with learning disabilities and autism. What we want to do is focus on the learning from some of the mortality reviews so we can really demonstrate why they are so important. So we move on to the next slide. Are there any questions from anybody? Please stop me.
Sorry, Alison, I'm going to give you a couple of minutes so we.
Okay. So just to make you, just to sort of bring back to the long-term plan, I don't want people to walk away today thinking that they are going to be the 3 key areas that we're focusing on. There will still be an ongoing oversight and support and assurance around all of other elements of the programme. So looking very, very closely, we talked about DSRs, the CETRs and CTRs. I've mentioned that now within 5 days of admission, we're still focusing on implementing the learning from those mortality reviews. Everybody's going to have their annual reports published by September. We're putting in some additional support and governance around that, and we're looking at about how we can then start to take forward that learning and make sure we've got quality improvement plans in place, and we're looking at following that up, making sure that we are actioning some of those recommendations. There will be a refresh of the host commissioner assurance in September that I've been made aware of this morning, and we will continue to look at some of those quality issues around seclusion and the use of restraint and the wider health inequalities around screening, IMS and VACs. And Stomp and Stamp is starting to be put back on the table, and I think in the context of restoration and recovery, anecdotally we did see an increase in the use of antipsychotics across this patient cohort during COVID, so there'll be an increased focus on that again. And I know that Richard Farmer in my team has just gone out to colleagues to reach out for partners to work with us in the continued development of our autism strategy, so thank you very much for that. So have you got anything else? I think they were my 3 slides. There's a few comments. Anything else?
So if we pick the comments up in the chat box, because I think we're running behind time already. So there are some comments, some questions in the chat box, Alison. So maybe you can respond to them.
Okay, so James, you've asked who we've approached to the LDA boards, the primary care boards. I've been speaking to Caroline Temmick this morning. Okay. And Passion to Reduce Health Inequalities, yep. Easy read, yes, absolutely. So just to give you an update there, I've just gone out to advertise for quite a few posts, and one of those roles is a new comms and engagement lead, and they are their job description sort of describes how I would like them to work with our experts by experience, making sure that we're using easy read versions for everything that we're doing, and making sure that there's a whole wealth of information accessible to you all, because there is a lot of stuff out there. Actually collating it and getting it into a space that's usable and accessible to everybody is quite a time consuming job. So we're going to put a learning disability and autism newsletter out, whether we do it on a quarterly or monthly basis, but that will include access and links to easy read versions for everything.
So can I intervene just so that we get back on track with time?
Yeah.
I'm happy to sort of forward on the other queries, Alison, or we can pick them up later in a Q&A session. Have we got anyone from SpecCom for an update? No, Vanessa. I thought I did see Gavin.
Yeah, I can see Gavin Thistlewaite's on the call.
Yeah, Gavin, did you want to update on SpecCom, or
what was the specifics on the SpecCom update? Was it I've got
Vanessa sent a couple of slides. Do you want to move along?
Please, yeah. I haven't seen these before, so I'm sorry about that.
Okay, well, let's skip that then. The slides are there, and we'll share it after for information. Jan, if we move on to the next slide for mental health. Okay, so from the mental health sort of perspective, we thought it would be helpful to just produce an overview of mental health delivery of services that we think support winter planning, because we really want to focus on the winter planning. So we've got a list of services we think directly impact on winter planning, and please let us know if there's any other service we should be considering, but this is what we've got so far, and this is how we've mapped it out in terms of what are the highlights, some of the issues, what plans we've got in place, and any additional support we think we need. So Sylvie, are you okay to just talk us briefly through the crisis elements of it?
Yes, of course. Good afternoon, everyone. My name is Sylvie Thorne, and I lead on all-age mental health crisis for the networks across the South East. So just to pick up on sort of key developments really in crisis and highlight some emerging themes in terms of risks and gaps that we've identified and the support that we've currently got in place or planned. So in terms of crisis lines, we know that we have 24/7 provision in place across the whole region now, which is a significant achievement. Providers have recently participated in the National Crisis Single Point of Access Survey, and this set out to understand the trends in activity and demand, to benchmark and understand the variation, and then to shape and inform the future crisis offer. We expect feedback from the national team in September. However, there are some themes that are emerging, which suggest that there are increasing demand in most areas, but despite that, services are managing to meet this and anticipate they can manage a 10% surge, which is very encouraging. A few areas are yet to be using NHS 111, but all report they have plans in place to actually address this. So that's all very encouraging. Mental health diversion hubs. We know that many areas in the South East have put these in place in response to the pandemic. However, initial feedback has been that the demand hasn't always met the expectations. And as a result, some areas are considering whether to stand these services down. The national team are currently collecting evaluation audits from around the country with the intention of collating and learning into one summary document for wider dissemination. And we've had very good engagement within the South East. Today, Oxfordshire, Buckinghamshire, Berkshire, Surrey and Sussex have come forward to contribute to contribute their local evaluations to the wider piece, which is great. In terms of crisis alternatives such as safe havens, crisis cafes, etc., we know that provision varies in each area, but we don't currently have any clear mapping across the South East, so we don't really know what's available where, but there is an offer from the South East Service Improvement Team to look at that in the short term, so that would be a good thing. Mental health transport, currently not full coverage across the whole region. Bucks, Berkshire and Oxfordshire are working with Milton Keynes colleagues looking at a Thames Valley-wide model, and the network is supporting a workshop next week to launch this work. The intention being that any learning from this will be disseminated wider across the South East. And then just to pick up on out-of-area placements, providers participated in the Stocktake survey in July, which was designed by the national team. The initial results from that revealed that there were a few areas in our region that are at risk of not reaching zero by the end of the year. And we plan to work with these areas and our national colleagues to develop a tailored support offer, should that be welcomed. In terms of liaison psychiatry, all South East hospitals are assessed as being in scope for Core 24 and have now received transformation funding. We haven't got a support offer planned for that particular piece. So I really would welcome any thoughts as to whether anything would be of particular interest. For instance, we're following up our July best practice event that we had in July with one in October. And we initially thought that we would support the transformation process by looking at focusing in on crisis alternatives. But alternatively, we could look at liaison psychiatry. So any thoughts around that would be gratefully received.
So just to
and I think that covers it all.
Yeah.
Oral.
Yeah, brilliant. So just to follow up on Sylvie's, update, in terms of the liaison piece, to clarify, it's all Southeast hospitals assessed, being in scope, have received the funding. So not all of them. So yeah, thank you for that. I think it's also important to factor in, what we're doing in our mental health in patients, and not just focus on patients turning up at ED. So, we are, as a cell, closely looking at the SITREP for mental health in patients. And what we have observed is we've got a few of our providers reporting near 100% occupancy on PICU and adult mental health beds. So we are looking to put some support in place around that in terms of providing a webinar on best practice around inpatient flows, looking at length of stay and detox data, etc. And then obviously we're looking to plan in the medium term, to support our areas with their planning for community and crisis alternative transformation funding for next year. So that's to come. So any feedback on that would be helpful. Have we missed anything? Is there anything we should be looking for? Do people want some other support, etc.? So please come back to us either in the chat now or directly to Sergi or myself. Next slide, Jan. So the other thing I briefly wanted to update on, and everybody already knows this, I would expect, is mental health planning. So this is a list of the resources that we've got in place. To point out, we've got weekly planning support sessions on a Tuesday. So one happened yesterday, and that focused on finance. It was very well attended, and the feedback was people found it quite useful. All the sessions would be followed by an updated FAQ document on the National Teams collaborations platform. And there's some other resources at that link as well. And here's a table with some more specific links to any queries you all might have around mental health planning. And the deadlines everyone's aware of, it's the 1st and 21st of September. Great. Next slide. Unless anyone's got any burning questions on that. I'm trying to look at the chat to see if there's anything in there. So please raise your hands and then I can identify if I need to bring you in. Good. So next slide, please, Jan. Okay. So that's the updates from the program. What we wanted to use the session particularly for was to focus on winter planning, and we've got a representative from the regional planning team, Francis. I think Francis, you're on. You can.
Yes, I'm here.
Brilliant. So I thought it would be helpful to just outline what the regional approach to planning was. So that's what this slide is about. And Francis, I mean, you can tell us the nuggets of it, but I think the key thing to take away from this is mental health is a priority in the regional approach. So Francis, was there anything you wanted to sort of...
Yeah, sure.
Yeah, on this, yeah.
So to say hello to everyone, my name's Frances Woodruff. I'm the Regional Head of Urgent Emergency Care. I'm not in the planning team, fortunately. I've got responsibility for the ops and performance of Urgent Emergency Care and then for the transformation programme. But part of that includes winter planning, of which I have accountability for. So we've taken a bit of a different approach to overall winter planning this year within the region, being mindful of both COVID-19, the existing incident control structure, and also EU exit. So there's a much more integrated approach to the management of winter going on. But as Oral said, we've been set a number of national work streams to ensure are included as a fundamental part of winter planning, of which mental health is one of those. So we have sent out a document to all our urgent emergency care leads within the region and all STP ICS accountable officers, asking for winter plans to be submitted to us by the 1st of October. Being particularly clear that we need to understand how we will have safe delivery of services for patients. And as Oral said, there was particular reference to mental health as one of those cohorts of patients. In conjunction with this, back in June, we did a co-designed urgent emergency care strategy with UEC leads across the South East and accountable officers, and delivery of safe mental health provision away from emergency departments was absolutely cited as a key priority for all geographical areas. So we're absolutely keen and wanting to work with the mental health team to ensure the best care for patients in the right locations.
Yep. Is that everything, Frances?
I think so. So, I mean, effectively, the winter period that we talk about is December through to Bank Holiday Monday in April. But what we'll be looking for systems to be able to demonstrate is how they plan to deliver safe and timely care for mental health patients. I know Bobby's on the call from the national team, and we had a call just before this to talk about the formation of key lines of inquiry and any specific points that we'd be looking to reference in mental health services. So my expectation is that something will come out over the coming weeks to identify any particular areas of focus for systems.
Yeah. Next slide, please, Jan. Yeah, so just to follow on from what you've just said, Frances, I think we've put this in to show what the current sort of reporting arrangements are for UEC.
Yeah.
And I think it would be helpful to, have a discussion with our systems about what reporting currently exists for mental health, or what would be useful for mental health, so we can factor that into your sort of planning process, Frances.
Yeah, absolutely. So there's a number of national reports that go in every day that we urgent emergency care, but they're primarily related to acute. So we receive every day the number of patients through A&E, the number of patients admitted, etc. And what we do also receive every day from each of our acute organisations is any patients who spend more than 12 hours in A&E following a decision to admit, so who breach the 12-hour DTA standard. But what we're looking to do, and what Oral and I have talked about, is how can we get a better understanding of the live picture for all our providers, both in acute and non-acute settings, of what the pressures are each day. And there's a thing called OPAL, which is the operational pressure escalation level, that is set every day for each part of the system. But all the systems I've worked in, mental health has been quite a small component of that. And actually, the understanding of the key pressures of mental health contributing to the overall OPAL level is quite small. So typically, where I came from in Bucks, we only really focused on out of area patients as one of the key metrics of pressure in a mental health setting. So what we're keen to do is to revise the regional OPAL framework, which we're doing in conjunction with a number of ICSs, including Kent, Surrey and Frimley, but really keen to ensure that that doesn't just focus on UEC pressure, it also focuses on pressure in our non-acute settings.
Yeah.
Is that all right, Oral?
Yeah, that's helpful. So I guess it's just to open up the discussion, really. What do people think would be helpful? So a couple of years back, we did have a sit rep on mental health patients turning up at ED. So I think that was coordinated by the national team. But would it be helpful to have something similar for occupancy in our inpatient settings. I guess that would be sort of relevant for Opal, Francis, would it?
Yeah, so I mean, Opal tends to look at occupancy, demand, whether you assess demand via your out-of-area placements or your waiting list of patients coming into your beds. Staffing tends to play a role in Opal as well, so if there's particular challenges with a shortage of staff, that would factor into it too. What we have for the physical health side of things is a system called Shrewd, which provides live feeds of data through for system partners to be able to contribute to the overall picture of the system. And Oral and I briefly discussed whether it would be appropriate to look at mental health also contributing to the Shrewd reporting tool, just so that rather than creating another mechanism of you guys submitting either a sit rep or another way of communicating information with us, it came electronically via a process that already exists for some of the other services.
Yeah. So I'm seeing in chat a message from Andy Erskine saying Surrey and Borders have got their Opal framework and they're testing the thresholds at the moment. So that's really good. That looks like it can give us some ideas to think about going forward.
Brilliant. And certainly, Surrey have been involved in those conversations with us.
So the plan is we are internally testing, and then we're going to go on to My Beautiful Information, which is the system that's used across Heartlands. So it will show against all of the other acute trusts and other system partners. So we're just testing it, and they're building a private page of MBI so we can check it flows properly. But that's the plan in place before winter.
Right. That's really helpful to know, Andy. So I'm just wondering how we take this forward, Francis. Would it be helpful if we sort of link up out of this call and agree some people we can work with to give you some input? I think you're frozen, Francis. I can't hear you. So I think what we'll do is we'll sort of take an action to, work up some sort of group. Are you back, Francis?
Yeah, I'm so sorry. I dropped off accidentally. Wi-Fi died. Yes, really happy to ensure that mental health has a very strong voice in our designation of our pressures this winter. Really keen to ensure that it's represented as part of the Opal calculations. And if we can simplify the reporting processes, that would be really helpful too. I saw that Bobby had his hand up and just wanted to bring him at this point, if that was okay, or just
that's fine.
Going to be the national pitch.
I don't think I'm seeing the hands.
Okay, so Bobby's got his hand
Go
up,
ahead.
so somebody else.
Go ahead.
No, just not much to add. So just wanted to, on metrics, I think what Andy has posted in the chat looked quite good, I think, for me, for mental health. So I was going to ask Andy, it's one of, in the out-of-area placement stock take that you may be aware that came from Ruth in the national team via the region, I think one of the most common bits of feedback we got was that mental health trusts and systems felt like they didn't have the same Opal type of escalation procedure. So great that Francis is bringing that in, and you guys are making moves to be joined up in the southeast. But I wondered, giving people a framework like that to work from might help nudge that. So I guess it's a question a bit to Andy: would you be up once you're ready for sharing that and seeing if other people might find it useful? I think they probably will, and it might help us be able to nudge that join up as well as a bit of a lever. That was all I wanted to kind of on that.
Yeah.
Oh, one other thing. Sorry, I should double check if because during COVID there was a sit rep for mental health, and that did have live daily bed occupancy data from every provider by bed type. So I can't remember if that's still continuing, or if it is, then that's being collected. So
it still is, yeah.
Yeah.
But I think there's other things that we wanted to look at as well in terms of out of area placements, length of stay, that sort of thing.
Yeah, I think all of the kind of stuff on Andy's, the thing Andy posted. Yeah, definitely.
So I think possibly what we could do is link up with Andy and Francis out of this meeting and decide what we would want to take forward and maybe propose for your process, Francis?
Yeah, that would be great. Certainly really keen to involve mental health in our winter planning process, really keen to ensure that it is a key aspect of what we do, and that we support our patients to be cared for away from emergency departments wherever possible.
Yeah, I think that.
Well, it's Rob Bale here from Thames Valley.
Hi,
Interestingly, I've had a series of emails today as well from my internal services about winter planning, etc. And I think a number of areas are probably doing similar stuff with Opal status. And I wonder whether Carolyn and Sylvie and colleagues might want to contact the emergency service leads, mental health service leads for the different trusts, because it would be a shame that everyone starts reinventing the wheel. I spent hundreds of hours discussing Opal status last week and how mental health fitted in, so I think it'd be really good to just get those leads who are doing it to pull together. Similar stuff to what Andy's done. It's all good stuff, but let's do it once.
So what we'll do is we'll definitely arrange something, outside of this call to get everybody together who's doing something about it. So we have a regional sort of approach, and we know who's doing what and who needs a bit of support, etc. And Bobby, you're welcome to be involved in that as well.
Thanks.
Yeah, sorry. Good. Is there anything more on that, Francis? I think we've done that.
No, that's it for me, thank you.
Right, okay. So, next slide, Jan, if that's okay. Okay, so just bringing us back into winter planning for mental health. So last year we got some money, 2.7 million, for winter mental health projects. And the CSU supported us with allocating the funding, and they did an evaluation of those projects as well. It was a bit light, obviously, because of COVID, but we did have some key findings from the evaluation, which I just wanted to go to. So this slide is just basically saying we had 2.7 million, we had 51 schemes allocated to. Most of the schemes were around flow, around urgent and emergency care, but we did some, around acute mental health as well. Next slide, please, Jan. Sorry, getting distracted. Jan, next slide. Okay, so based on the feedback, so we had these are the key feedback from that process. So it basically says the schemes which were rated as most effective appear to be those that support the flow for patients through the system. In some cases, those that added additional capacity. The bid process was managed at pace because we got told with not much notice that there was this funding, so it meant there was some delay to implementing projects, etc. A lot of the systems reported that they would really prefer earlier notification if funding is going to be made available so that they can operationalize, etc. And then standard feedback was, temporary workforce remains an issue across the region during the winter. So, maybe something we can think about in terms of, the projects we sort of prioritize. So, based on these findings then, I have explored with Bobby and the national team whether or not there might be funding for this year's winter for mental health, and I don't think there was the commitment to having that funding for similar winter funding for this year. But Bobby, is there any advance on that, or any sort of national headlines around that sort of thing, so we can prep ourselves?
Yeah, so yes and no. So I guess just on the point about, I mean, completely get it about the time period that people get given for this. What I say every year is that every year we get told no, there's no winter funding, and then every year it does appear at really short notice late on. So I will always say, if you can just permanently have things or try and plan things that could be stood up at short notice, and I know people kind of do that by now. That's one bit of advice. It is sometimes out of anyone's hands. It emerges from either underspend from you name it, where it comes back to us from different parts of the system, and sometimes government just suddenly announces something in the middle of November or December. So some of that is unavoidable. However, what I would say now is that it's going to be really hard to make the case for additional winter funding when we have a 5-year long-term plan profile, and really most CCGs aren't using the mental health money that has been allocated for mental health for these types of service areas to the full amount at least. Lots of CCGs are doing brilliant stuff. So it gets quite hard for us to make a case, because Treasury and DHS say, well, you're not spending all your money, but you're asking for more. And I know in the reality at a local level, it's easier to use a bit of ring fence money than make the case. But having said it, so I think that is the general line and the official line and the steer that I think we're planning. Lots of areas are saying they're going to struggle to spend the mental health investment standard this year for obvious reasons, you might argue. That said, having said all of that, we are maybe making it so that I'll be open and upfront. The Department of Health has asked us if there will be any additional cost pressures this year resulting from COVID or anything else. So we have responded, and we are letting them know what we think some cost pressures might be linked to the OPES ambition. And all I know is we put that in. I don't know. They're quite coy, a bit like I'm being now, about whether that's going to be successful or not. So the answer, as ever, is maybe. If there is, I'm hoping it might be it could be a bit more than the kinds of amounts we talked about last year, what we bid for anyway. But what I would say is, there is a lot of money in CCG baselines that most people are saying they are going to struggle to spend. So please do spend that, and kind of, if you can, do away with the long, difficult contracting and so on of commissioning new things like we might do in winter. Then I guess we would encourage that, like happened during the COVID lockdown period. But yeah, that's all I've got really on winter funding.
Yeah. So thanks, Bobby, for those headlines. So I think, what I'm hearing is we might have money, but I think the best advice we can give is have a bank of projects that you can, use if money does come at the last minute. So you don't have to struggle to get good quality sort of projects at short notice. So on that note, I think what we would move to now is the next agenda item, which is about some of the projects from last year, that we think were quite good and had some good outcomes from the evaluation. But we're going to kick off with mental health access via NHS 111. So this is Bobby and the national team are doing some work on this, so they're going to tell us about that project. But also we've got Hampshire and Isle of Wight, who have already implemented this. So it's not even a project, it's their business as usual now. So they are going to support Bobby with this piece. As you know, it's quite a relevant piece for the region. So Bobby, over to you and company.
Thanks. And I apologise, I have to leave a hard deadline at 4, so I will be going in, but it'll make me canter through. So very quickly, if we could press move forward, please. Sorry, this is an old slide, I think. Sorry, I think we've got the wrong slide pack. So none of these stats apply anymore, basically, which is great. Can I share my screen potentially?
Yeah.
This is the wrong slide.
No problem.
Sorry, I'm gonna bear with me. I'm not sure. Oh yeah, here we go. Sorry.
Bobby, would you mind sending them through to the MHLDA inbox or to me directly? That's j.ratcliffe3@nhs.net when you're done, so that I can amalgamate them into the other
Yeah, absolutely. Sorry, I only sent these across quite late yesterday, so apologies for that.
That's brilliant. If you just send it through when you have time.
Okay.
Thank you.
Okay.
So, can you see my screen now? The picture of loads of arrows and squiggly lines.
Yep.
Yeah. So I guess why are we the overall, I guess, people have asked about the ambition in the long-term plan, which says that NHS 111 will be the single universal contact point for urgent mental health services. And I guess this picture you might have seen in different presentations is a bit of an illustration of why, in that I would say so there are probably two of the most common concerns I've heard since working on crisis care is, number one, what do I do? Where do I go to get help in a crisis? And this picture from a service user group, I think, probably depicts what a number of patients and professionals have probably felt over a number of years. A very messy system. It's not clear, especially if you're not known to services, and the potential of having a number, 111, a simple 3-digit number that crucially that people feel confident they will get a good response from. You can call 111 now for mental health. You probably, unless it's an area like Sonia's and maybe some others, won't get the greatest expert, compassionate, humane response at the moment. So that's why this is an ambition, quite ambitious and potentially quite exciting. So this is an old slide now. You can see the update that everywhere now. So the slide that I asked to be taken down was an old slide saying, most areas don't have 24/7 crisis services, and most areas are still only open to people already known to services. Now, as of May, through the 24/7 crisis lines, we could, it's great. We've got 100% coverage of 24/7 open access help and support for mental health crisis care. Huge step forward. Obviously, that there'll be a lot of variation behind that. That has by a long shot not sorted. Whether everyone can necessarily get through, if the telephony infrastructures are robust enough, and also what do you get? What's the quality of care you get? And then I should speed up, but skipping through, I guess the bottom box, as you all know, the second box quickly. Everyone is investing in what sits behind those crisis lines. So not just a telephone line, but actually facilitate access to a much more comprehensive system of urgent mental health care and community mental health care. And then hopefully we can make 111 the access point. The bottom point, the NHS.uk page has been, there is now a new service finder. So for the first time at a national level at winter, for example, we can say, you can find your local crisis line number on NHS.uk if you have urgent mental health needs. We've never been able to say that at a national level before because of the variation I've described. It's only been able for local advertising if they've got that open service. So I guess the aim is we've got these crisis lines, we've got investment in better crisis pathways. How do we connect that to 111 so that when people dial 111, they get quick access to a mental health expert and can have access facilitated to the rest of the pathway, an urgent face-to-face assessment, benefit support. It might not be NHS support in the pathway, housing, you name it. How can you connect 111 to the urgent mental health crisis care pathway? If we can move forward, please. We can move to the next slide, that would be great. And what the next slide will show is we believe, or we understand there are two models. So two models of how.
Bobby, those are your slides.
It's your slide.
Oh, sorry, that's what. I was like, what a muppet, sorry. Why is it? You can see me not pressing forwards as well. So two models of care. So the first one, I think you may be familiar with. You may have heard from Cambridge and Peterborough and quite a number of other areas where there's a self-select option. So you dial 111, press the mental health option. In this case, mental health, press option 2. And you go straight through to the Mental Health Trust single point of access. And a great development done well. So these are the services that are showing us nationally what can be done and shaping the national ambition. So they're going ahead, if you like, of any national specification. Sonia, if it's okay, could I go through first and then come back to you for number 2? Number 2 is Hampshire and Isle of Wight, and Sonia's got some slides she's going to present, but I do have to go at 4, I'm afraid.
Go ahead, Bobby.
And that's a different model. I'm not going to go into it because Sonia will, but I think, can we have, one thing, we're developing a national specification. Can we get the best bits of both of these models is a question. And, every model has its strengths and maybe gaps. Can we have a specification that addresses the gaps? And I know that both of these areas are trying to learn from one another and fill any gaps that might exist in their current very innovative services. Just very quickly, these are some areas that have gone live with a 111 offer for urgent mental health before any national kind of mandate or specification, and so that's great. Good for them. And I'd just like to direct you to the bottom bullet. I guess what we'd say, you don't feel like you're behind or you should have done this yet. But if you feel ready to and you want to go live, do progress ahead of what we want nationally. The reason we haven't mandated it is because we don't want everyone to have. I think we want an area to feel comfortable that they've got adequate crisis services in place that sits behind 111 before kind of opening up access via 111. We don't want to advertise it and people to believe it's a poor service and lose faith in that as an option. However, what can be done in the meantime is that there has been some DOS guidance, a directory of service guidance issued to all DOS leads to help profile the crisis care lines that are now available everywhere onto the DOS. So when someone calls 111, even if it's not that formal integration like Sonia is going to describe, the 111 team can still either warm transfer or pass the person on to the mental health crisis line if that is a better option and if they don't feel like they can meet the needs on the phone. So that can be done now everywhere, and we would encourage everywhere to do that ahead of winter and NHS 111 First rapid implementation that's happening. And then very quickly, what is NHS 111 First? And this is where it's not my policy area, so forgive me if I can't answer everything about this. But essentially, I think people have asked, does it apply to mental health? And at the moment, yes, I think we would say yes, it does. But the principles do apply in that we've got these crisis lines and we want people to phone them ideally if that's a better option for them to phone first, and then in doing so they might have a better experience. It will probably usually be that A&E shouldn't be the disposition, even though we know historically it is too often, but you should in most cases be able to have a community crisis assessment, or people could attend a sanctuary or a haven or whatever other options are in place. Obviously some people will need to go to A&E. I think mental health might even be in a sort of advantage, and I think out of A&E urgent services or service models at least, there are more proven models I think for mental health than a lot of physical health kind of conditions. So things like crisis cafes, having crisis teams that can visit people at home within hours, it's not the hugely done thing across loads of physical health pathways. So it might be that mental health can actually do better at NHS 111 first in time. However, we need to be, the risk of 111 first is the age-old kind of prejudices in A&E that A&E isn't for mental health, and it absolutely obviously is for some people. And even if someone attends and it's not felt right, then people should not be made to turned away, made to feel like they're wasting time, and a referral should still be made to liaison psychiatry. This is in the 111 first guidance. And then very, very quickly, sorry, I'm running out of time, but the next step. So I'll summarise this really as we are going to develop a draft specification for connecting 111 to mental health services. It will pretty much build on the two models mentioned today, and try and engage on that. Basically, we want to get as many views as possible, probably in the next few months, to then work up, maybe by the end of this financial year, a final national specification, and then it will kind of be the green light for everyone to go and implement. But what can you do now ahead of that formal integration? The bottom box. So everybody can include the mental health crisis lines in their local comms in 111 First and Winter comms. I've mentioned about profiling the crisis lines on the local directory of services so that 111 can refer or transfer people. Ensure that mental health services are part of NHS 111 First implementation. That's happening rapidly everywhere now, and we need mental health sort of round the table. Keep investing in community and crisis services. I think that goes without saying. And then maybe if you feel ready to start thinking now about how you would like to connect your system to what model you think would work best for your area. And I've just put the link to the nhs.uk page at the bottom if it's helpful for your local comms or sort of regional comms maybe, about how you can find your services. And I'll stop there.
Okay.
And I'll stop sharing my screen.
So probably, and I think definitely if you can send us the updated slides, because we'll share the pack after, so everyone can have that. But thank you for that. And if there's any questions, we will come to you.
Thank you, and sorry for that. And thank you, Sonia, for switching. You'll love what Sonia has to say. So I'll leave you now. Thank you.
Bye. So I'm gonna take control of the screen, and I'll put Sonia's slides on. Tell me when if you can see it, Sonia.
I can, yeah. So if you just, I'll whiz through them. Can you make them so they stand out in a proper presentation?
Yeah. Can you see it now?
Yeah.
Okay.
Brilliant. Okay, so just for those who don't know me, I'm Sonia McLean. I'm a Senior Commissioning Manager for Hampshire and the Isle of Wight. Bobby and the team wanted me to be able to share with you really what we've done in Hampshire. So just really to demonstrate to you what our geography is. I won't whittle on. So we've got just over 2 million sort of population. Our 111 sort of mental health 24/7 provision covers the whole of our SCAS South sort of footprint. So we also capture Surrey Heath in there as well, and we straddle Surrey and Borders as well. So if we move on to the next sort of slide. Have you got that, Oral? Can you move on?
I've done it.
Okay.
It's probably delayed coming. Yeah. I've done
Okay. Okay. Brilliant. So the green flow at the top basically describes to you the offer that we've got for people to use the online forum. So we can use 111.nhs.uk. So anybody with a mental health presentation, we've got the added bonus on our provision to be able to use online forum. When a lot of our patients are increasing the use of using online because actually they find it a much quicker way to get through to our mental health nurses. But actually conventionally, if you use the phone, you phone 111, you'll speak to a 111 health advisor, and they will go through NHS pathways. They will ask you questions about your health, and depending on the presentation at the time, the sort of the symptoms that you're presenting with, that individual will get a call back from a mental health nurse, and the time frame in which that callback is given is based on that individual's clinical presentation. Now, ultimately, if they have overdosed and it's a significant overdose, then they will ultimately get an ambulance being dispatched to them straight away, and the mental health nurse will support the paramedics on scene. But then what the patient will get is a phone call from the mental health nurse, and the mental health nurse will go through their own triage and then decide on the best route for that individual. And then the next slide will talk a little bit about that triage process.
Come on.
It probably will. I think I might guess what the next one is. If I can't, it's not coming up oral. Okay, so it has now. So I've worked closely with Modestus over the last couple of years, and the Cambridge and Peterborough model is an excellent model. So we also using the UK mental health triage scale within that. And that mental health triage scale, to be completely honest, does give us a really good consistent response for every single contact that is made to the mental health triage service, and it also grades those contacts so that individual gets an appropriate and timely response. The triage scale does support individuals with regards to improving communication with their carers, so we can very quickly outline those expectations that we'll deliver. There are clear principles based on that clinical presentation for that individual, and they are not based on service availability at any point. It is based on the needs of that individual at the time, and we deliver that element of care based on that individual's needs. So that blue light response, if that's what's needed, that police response, if that's what's needed, or any other sort of support service. We don't actually give a scale to the triage until the end of the assessment, so we're able to capture all of the information from that individual, whether they're a looked after child, whether they're living at home with family members or living alone, and then we'll be able to give that a scale, and that scale then will give us what response that individual needs. So the next two slides, I've literally entered into there what we base our triage scale on. It's very similar to the Cambridge and Peterborough model, but obviously how we commission our response times with our mental health providers. So a category A ultimately would be that individual is self-harming, significant overdose or attempted suicide. So we'll get that immediate response. And like I say, we've got a straightforward transfer to Hampshire Police if we need that. Likewise, Hampshire Police have got that emergency sort of response to our team if they need that as well. Category B is that 4-hour response. So that's when we would then have that conversation with liaison crisis teams to be able to get that individual that face-to-face response within 4 hours. And then your category C is your 24 hours. And then the next slide will provide you with category B, D, E and F. And they are graded based on that person's presentation and ultimately those services then that will support that individual. So you then start capturing your sort of iTalk or your safe havens, your crisis sort of lounges, your sanctuaries, whichever sort of things you sort of call those services. On the next slide, when it comes up, so this is the collaboration that we've got with our providers. So our mental health team are co-located within our ambulance and 111 environment. We are very lucky. SCAS is our 111 provider as well as our 999 provider. So we are able to mobilise our mental health rapid response car if a blue light service is needed. So, but that service is only running Thursday through to Sunday. So we've got a paramedic and a mental health nurse working in our peak sort of time. Outside that time, we'll mobilise an ambulance if that's required, and then those paramedics on scene will point those mental health nurses to get some advice and guidance, and hopefully try and prevent that ED attendance, and get sort of that individual the help they need in their own home, within the response times that we've defined, that clinical sort of triage. We collaborate with 5 mental health providers across our region, so Solent NHS Trust, and they are our CAMHS provider for Portsmouth and Southampton. Southern Health are our lead provider, so they actually employ all of the mental health nurses. Although this service is co-located in 111, it's a Southern Health led service, and they do that in collaboration with those 5 mental health trusts. So our Hampshire CAMHS provision, Isle of Wight Trust and Surrey and Borders. We could not deliver this service without the strong collaboration and links that we've got with those 5 mental health providers, plus access to all of those mental health systems. So unfortunately for the mental health nurses, they have to navigate 4 mental health patient management systems, but actually when they know what area that individual is from, they can look up their records, they can see access to their crisis plans, their contingency planning arrangements, any of those sort of family sort of network contacts. And then from that, we can refer that individual directly into community mental health, crisis and acute mental health services, psychiatric liaison if that urgent sort of support is needed. We can refer into safe havens. We can have a conversation with our local authority AMP teams. We can have a conversation with there's a social worker that also works in our SCAS environment, so we can have a conversation with them if there's concerns about elderly and sort of placements. What can't we do? There's lots that we still can't do and that we're developing. And I think the next slide talks about some of the developments that we are working on within our environment. So like I said, we've got online in our area, so we capture all of mental health online. We are really lucky to be part of the South East region bid, and that's actually been awarded. So we're going to be part of the Mental Health Veterans High Intensity User Service across the whole of the South East region. So we're going to be working with a lot of the other 111 providers to support that. We've just agreed a collaboration with No Limits, so our children and young people in Southampton, for No Limits to contact children and young people within 48 hours of their contact in 111 where authorisation and consent has been given, because actually there's a lot that No Limits can do with our children to be able to provide early intervention and prevention for our children whilst they're waiting on that CAMHS referral, and they may not ever need that sort of CAMHS support. We are supporting 111 First for mental health, so Portsmouth have been part of one of the accelerators for that, so we're going to be strongly developing our pathways with 111 First. We offer text messaging to our patients, so when they've had a contact with the mental health nurse, we can let them know that we've directly booked them into a GP appointment, what time that appointment is to remind them. We also provide them with advice and guidance in that text message to help that individual when they do need some to remember what that call was about, what sort of things have been set up for them. And whilst 111 are exploring the video calling options, we'll also link automatically with those sort of video calling or Skype calling when they come into place. This was very quickly just to provide you with a little bit of an overview. I could bog you down with big data, but I didn't really have time. So once the individual has had that initial sort of questions about their health from the health advisor in 111, once they've then spoken to the mental health nurses, we're seeing a massive outcome for our patients with regards to improved patient pathways. So we've actually had an 88% reduction in our ambulance dispatches as a consequence of those mental health nurses being co-located. 100% reduction in recommended to attend ED. So we are diverting people away from our emergency department by getting them the right care from the mental health provision where we need to. Ultimately, where patients do need to go to the emergency department because they've overdosed or self-harmed, we're absolutely delivering that. But a 95% reduction in primary care endpoints. It's it's very important to remember these are endpoints that we are changing, because as we know, patients will still tip up at the emergency department, will still go to their primary care clinician, but what we are being able to do is to improve the patient pathway so they don't have to do that. And we've actually increased home management and self-care from 11% prior to the service being set up to actually now being 80%. And there's a bit of a slide here on what our COVID demand has been over the last few months. So we've seen a massive increase in COVID anxiety, and we've managed that significantly well, to the point where I commend the team every single day for their hard work and effort. And as you can see, a 200% increase in our CAMHS, children and young people contact, with still the similar sort of outcomes that we have with regards to not having to go to the emergency department, and people being supported in their own homes. I think that's it.
Thank you. So, comprehensive sort of update on what you're doing, Sonia. I think, in the interest of time, if there are any questions, people can either pop it in the chat, or are you happy to take questions directly? We'll share the slides with everyone.
Yeah, share them. If you can share my email address with everybody, because I do need to go. I'm happy to talk to anybody, or James Carter can link you all with me, and Modestus can. So if anybody wants to chat independently, that's absolutely fine.
Brilliant. Okay.
Thank you.
All right, cheers. Bye. Okay, so we've got a couple other case studies from last year's winter projects that we thought might be helpful to consider in future projects for winter. So I don't know who's going to cover this. Sorry, Andy, are you happy to cover just some key nuggets from?
Yeah, very happy to, and I'll be very brief. So you've just heard Sonia, and I would absolutely share what she said about her service. As you saw, Surrey and Borders are a small link for that system, and they do some fantastic work there. You heard Sonia talk about exploring kind of video contacts, video assessments for people in crisis, and in essence, that's what the virtual Safe Haven has been doing for the last couple of months. So we have a network of safe havens in Surrey that, in a sentence, are safe places for people to go out of hours, that are designed as an alternative to A&E, can provide some kind of initial advice and potentially link people with a rapid response assessment if that's needed. And we've often, because of the geography of Surrey, we've often had comments that people can't get to their nearest safe haven, although we've got a number of them all over Surrey and North East Hampshire. And we had been trying for about 2 years to set up a video calling virtual safe haven idea. We put it on our winter pressures plan, but we just weren't able to get round the kind of information security accessibility concerns that were there at the time. And then COVID hit, and then the kind of revised guidance came out from NHSX. We mobilised Attend Anywhere at pace, and we were able to get this up and running, something we'd thought about for 2 years. We were able to get it up and running within about 2 weeks. All we've done is set up a link for each safe haven. You can click on the link and it takes you into a kind of safe and secure waiting room. And then you can have a video call / assessment with someone from the safe haven. What was great, and I don't know if the other slides that I sent across are part of the presentation or not, but what was great was that this was a service that was requested by people who use services, and through COVID we had some really nice feedback about how it was making a bit of a difference, and frankly we also had some feedback saying, you've talked about this for blooming ages, what took you so long, because it seemed quite easy to do once you managed to do it, which was a very fair comment from them. So I mean, from my perspective, it's something that if you're using video consultation, it is fairly straightforward and easy to replicate. And if people want specific technical advice and guidance, I'm not the right person to talk to, but I can try and help and support and connect you with the right people. what we're looking to do is similar to Sonia. We're thinking about whether this forms part of our existing 24/7 single point of access, so we can also have a kind of video assessment function working alongside our single point of access and the safe haven type stuff.
Thanks, Andy. So if people have got queries, we can link them up to you. And
of course.
Yeah. Okay, great. Okay, so we have another update for oh my gosh, my computer has just decided not to work. Okay. So as Gordon from Isle of Wight on the call, we've got another project from the Isle of Wight in relation to mental health practitioners in primary care. So Gordon, do you want to give us a brief?
Yeah, absolutely, Oral. So we established mental health practitioners, so primarily Band 6 nurses working in primary care, aligned with our GP practices, and I'm sure that you don't want me to read the slide verbatim. Suffice to say that we had an incredibly positive outcome from that, particularly from the practices themselves. What it did mean that we were able to improve our collaboration between the CCG primary care, the trust and the third sector as part of our overall mental health transformation and development work. What I think was surprising was the strong commitment from primary care networks to support this model rather than at practice only level. So they wanted to adopt a PCN level approach rather than it being an individual in a practice. Which was positive, and we were able to bolster the work that the mental health practitioners were doing with third sector recruitment of support workers. So that was incredibly positive. Challenge-wise, it was something new to primary care, so there was a lot of Hearts and Minds campaign that took place. It's also brought GP practices much closer together, where they were perhaps working more independently and individually, looking after their own practice lists. I think recruitment of RMNs, recruitment on the island is obviously always a challenge, and so recruiting RMNs without robbing Peter to pay Paul was a challenge, but we managed to work around that in partnership with the trust, which was good. And of course, COVID-19 had an impact on that work as well, where the face-to-face element of the service became telephone and online support, although that worked incredibly well with the robust infrastructure we've had. The numbers there, as you can see, pretty much speak for themselves. We had a 40% reduction in referrals to SPA. That's out with COVID-19 having an impact. And as well, 60 patients in 1 week seen by the mental health service was incredibly positive, because that's obviously clinical time for GPs. I think in terms of what else we can learn, you need strong mental health leadership in primary care and secondary care. There's got to be a trust element there, that it isn't just a shift of responsibility into primary care from secondary tiers. I think you need to understand your workforce issues as well. Make sure that the mental health and learning disability workforce, particularly in an area where we are very, very careful about the way in which we use our workforce, that needs to be understood. And I think it's also supporting the practitioners themselves, many of whom will have worked in a very different framework of operation, either be it through a mental health hospital service or a ward-based service or a mental health community-based service. This is a very different way of working, aligned to PCNs and practices. So strong clinical supervision for primary and secondary care was key. Here endeth the lesson. So I shall stop there. I don't know if there's any questions.
Yeah, thanks, Gordon. I was just saying, I had myself on mute. I was just saying, if anyone's got questions, we can link them in with you, if that's okay.
Absolutely.
Yeah, brilliant. And then the final project we have is a CYP one. So I don't know if we've got someone from Sussex who can briefly talk us through.
Yes, I'm sorry.
Yeah.
Sorry, someone was going to speak.
Sorry, Matt, I was just going to say we've got Neil just going to introduce you.
Oh, that's kind.
So go ahead.
Okay, so I'm Matt Stone. I'm the operations lead for a variety of services within Sussex Partnership Trust, including children and young people services. I'm afraid in me you've got something of a fourth reserve to come and do this presentation, but in light of the time and to take the lead from the two previous presenters, I'll keep it very brief. And people can ask questions, as you say, you can link them in with us. So this was a short-term, non-recurrent piece of money from last year's winter pressures money. The challenge that was identified in terms of winter pressures was that A&E is often the default pathway for young people experiencing a crisis. I use the term advisedly because it's not necessarily a mental health crisis. It may be a crisis of a number of manners, but quite often are considered to be a mental health crisis, and A&E is the default. That creates problems for the family, problems for the young person, and obviously has an impact on systems. So the challenge was that we have a very limited resource in respect of children and young people, specifically trained practitioners to attend to young people and assess and work with young people that have actually attended A&E. We have 2 whole-time equivalents to cover 2 A&Es across East Sussex. This is an East Sussex specific project. It's obviously A&Es open 24 hours, and presentations stretch across the 24-hour clock. You've got 2 whole-time equivalents to cover 7 days a week, 24 hours. I guess we can all do the maths there. So one of the solutions that we thought with a short-term piece of money, which was actually, as I say, particularly small pot, was what could we do to create a better pathway with some specialist intervention. And we looked to something that we had tried when we were operating services in Kent, where we worked with another provider, and as it turned out, that never really got off the ground for a variety of cultural and contractual reasons. But we looked to stretch our existing 24-hour adult A&E operation to stretch them down to work with young people presenting to the age of 14. There is some college guidance, and I can't remember quite which Royal College it is. I would imagine probably paediatricians that you're probably all more familiar with than I, which for younger people below the age of 14, there is college guidance that a young person presenting at A&E at that time of night, unless they're a really strong, the presence of really strong parental or carer support, should be admitted anyway. So that's why we picked the 14 as a cut-off point. The money was used ostensibly to provide training to the adult services from our CAM specialists, just to enhance their own levels of experience and knowledge. And then to pay for additional shifts so that there could be a dedicated worker to sit amongst their own adult colleagues and work until 12 o'clock at night. So the challenges, we'll do it the wrong way around. So the challenges were, as previously mentioned on a number of presentations so far, were the very short lead-in time. I think that the money was released sort of just after Christmas. By the time that we negotiated a variety of elements of resistance and concern, we really didn't get going probably till February. So we were talking about a couple of months. We delivered the training. The training was well received by our adult colleagues. And really, as I said, as previous presenters have said, I won't read the slides for it, but ultimately there wasn't really enough time to embed it. There wasn't really enough time to change culture within individuals' practice. But the early indications were that training was well received, and it did indicate that we were heading in the right direction. It, of course, as with many things, was superseded by COVID and the kind of imperative to divert everybody that didn't have a medical requirement from A&E. Yes, so essentially that was superseded, and our new A&E diversion pathway for children and young people, which is works in conjunction with our colleagues in A&E and adult mental health, has been very successful in picking up young people, safety planning with them and all their parents and carers, and then picking them up first thing in the morning. I think the future for us in our overarching urgent care pathway in Sussex is a blending of those two approaches. I think we should be looking to have another go at building on this this extension of adult provision, but also diverting young people that don't have a medical need, hooking up with 111 as previous presenters have talked about. So yes, it was a very short, but there were some glimpses of very, very positive practice.
Thank you, Matt. Thank you very much. So, so just to say thanks to Matt, Gordon, Sonia, and Andy for explaining challenges and successes of their projects. I think we've had 4 very good examples to consider for future planning of winter projects. So we've got some actions from this call. I think the key takeaway was from Bobby. There is no commitment just yet to funding for this winter, but talks are happening, there are conversations happening, so it's worthwhile considering what projects you might want to consider if money becomes available. And then we need to think about some of the reporting we might want to do for mental health during winter as well. So we'll take that offline, and we will share the key actions and decisions from this call to all the attendees as well. So just to say to everyone, thanks for participating, and we'll see you all in a couple of weeks' time again.
Thanks, Oral.
Thank you.
Thank you, Oral.
Thank you. Bye.
Thank you, Oral. Bye-bye.
Bye.